Meeting appointment.
Just because of fluid.
No, she says it doesn't hurt, just for the fluid. So we canceled it because we were dealing with the meeting, and then at the final visit, she had a decision, and she had to do it. So we went to the blood test. There's one indicator that's not like a test for arthritis, but it's like another. It's just like yellow. She says, and then Katie showed her elbow. She said because she's always had her ankle.
This is like osteoarthritis?
It's called juvenile, and there's a word, arthritis.
Which way?
No. Juvenile begins with an I. It's J-I-A. And they said it can come and go. I've been Googling it.
I know it will start soon.
Could be partly hereditary, but maybe
She's just
not.
going to get the blood.
I don't know. So she said, let's start her on like prednisone. She can only go on it 2 weeks. Anti-inflammatory.
That way you're on now.
Prednisone? Yeah.
It is. It's
No.
Je vois ici tout le
And
manger.
then she's also taking
Okay.
a high anti-inflammatory. And that is, and the prednisone is like for 2 weeks. Anti-inflammatory is, and then she gave you a refund. But
Yeah.
go back before, go back and fight.
So she didn't say anything about like activity and things.
She says she encourages activity.
So that's what I was saying to your husband, like I definitely think like strengthening makes a ton of sense. As long as they're okay with like activity and stuff, kind of question that. And I can read about it now that I know what it's called.
Yeah, let us know if you come up with something. She told her what sports we play, and she said as long as there's no pain or limitation, because she was surprised she didn't have less range of motion with all that. But she wants to see how she responds, and then we go back and fight it. And she also had an important advice.
Hello?
They just want to check it.
fun.
And she also gets a blood test. So it's like, oh my gosh.
Yeah, right. One thing after another. You just thought you were coming out of the medical world.
I know. But, you know,
Or is it going to be?
glad, but I hope it's not anything. It's not like definitive, you know, like, so there's no like one test, but
Right.
Right. Rheumatology is usually a lot of rule out.
Yeah.
rule out, see what your body
Yeah.
responds to. Maybe it'll just go away after the initial.
Right.
control.
Hello?
Okay. Well, I'll do a little research.
So when it's gone, I should be like 100 times better and everything.
I told her.
Seriously.
I'll be
Yeah.
able to shoot. It doesn't look
Right.
And I woke up this morning and my ankles didn't hurt at all.
Okay.
I mean, that's like huge right there. Like,
I know.
Like I
can
can
hear
walk
people
down
on
stairs.
Yeah.
Right. Oh, am I hearing now? You're
like
sitting over there at home? Oh, okay.
Yeah.
a lot of times people take these prednisone and they feel like a different.
Okay. Right?
The question's going to be like, once that paper is done.
Okay. We call this quite a different structure. Yeah. No, that's okay. So
Okay, well, she looks way better than she did 2 weeks ago.
Oh, did she?
You get it? Okay.
Yeah. Well, I mean, like last time I was like, this.
Those of you who haven't met me, my name is David Hawley, the corresponding secretary of the Central District. Welcome. Before we get started, I wanted to make a brief announcement.
I know.
Okay.
If any of you in the
Sugarcoat
Central
answer. I can
District
play!
are
Oh, wait.
in joining the 2016 Delegate Assembly, we are going to give you a warm welcome to come and join us.
Okay.
Participate in the process of
Yeah,
how
what's the story on that?
NYPTA
Yeah, my online
vision of the APTA.
web is a terrible thing sometimes.
You get a great opportunity to network with the leaders of our field. And it's April 29th.
I was
and
just, he didn't say no. He said.
so if you're interested, contact one of the officers for the Central District and
There's
we'll get
not
you all
real
set
solid
up.
evidence that it's
So we're happy to
that
have
it does
Julie
anything.
Lombardi here today,
There's
giving us a
definitely no
presentation.
indication that it's bad.
Julie graduated Upstate Medical University in
They have mine somewhere.
2008. Since then, she's done
Not
several
forever.
courses in vestibular
I mean,
rehabilitation,
you know, if he's comfortable
starting
with
with
it,
a course
maybe you go
at
for 2 or 3
Emory
months back
University
and then
School of
keep that
Medicine, directed by
So like
Susan
just when
Herdman in 2012. In 2013, she took the course Advanced Practice.
I mean, you're not gonna like
Therapy.
stop and like,
By
all right, we're gonna
Susan
scrim it down. You're gonna hold time out. I gotta
And in
play racing.
2015, she took the course Cervicogenic Dizziness, taught by Robert Landl.
But you really won't. So I would say like
She also
basic
has her
shoes,
certification in the LSVP BIG
through
approach to working with
whatever,
people
pick
who
a
have
day,
Parkinson's
through one
disease.
good at the end of January.
And a little bit more about her background, she has an undergraduate degree in fine arts and dance.
12 months is like the rule that
So you can imagine, I'm sure, Julie, you have a lot of great ideas about high-level balance.
Yeah, I'll do it.
and then some of them were.
Thank you so much for putting this forward.
Yeah, thank you for having me.
The
I don't foresee that happening.
So, kind of a strange setup, but I'm gonna have my back.
I mean,
to
like
the-
the
I don't
one
have
thing
a
that I was
clicker,
trying to
so
tell
I have
her
to kind of
is like
sit here.
there is some
Confused.
research that says like it gives
So
you
tonight
a
we're
little
talking
bit
about
more
evaluation and
support.
treatment for posterior semicircular
Down
canal,
a little bit, not
PCV.
right, so you feel the brakes and it's kind of like
The reason I chose this topic is
not necessarily
that
that
it
it's
is
like
the most
holding you,
common
but it's cute.
cause of vertigo that we're going to see as physical therapists.
It's bad if you do this wrong.
So the objectives for tonight are to
Never.
review the
I mean, I've had
basic
other parachute patients
physiology
that I
of
actually
the
called into
vestibular
the brace
system,
and it wasn't
discuss the various causes of vertigo,
like their knee. It was because I couldn't get
review
back
BPPV and test for the posterior semicircular canal,
have that.
and perform
She's the
treatment
opposite of
for
that.
the posterior semicircular canal,
All right, yep.
BPPV.
Good luck. Keep me posted.
What we're going to do up here tonight is mostly lecture. We couldn't move a
Yeah,
large
definitely.
map
I need to schedule.
here, and the
I guess I can look it up
front
online.
up here. So what we figured was there's diagrams of the
Well, I don't know if I'll be at the
treatment
first
in
one.
this, and then
I want to see what.
if after the lecture you want to come
Is it at
downstairs
home?
for demonstration and practice, we'll
All right, well,
do
that's
that.
more like this.
I'm out of town. First 4 games.
So
I'll definitely get to one. See ya.
the anatomy of the vestibular system, the peripheral system. There's 3 semicircular canals. The posterior semicircular canal, also called inferior, anterior semicircular canal or superior, and horizontal or lateral. Why is it doing that? There. Okay. The semicircular canals sense angular acceleration. This is a picture of a cupula with the hair cells projecting into it. The cupula sits in an area called the ampulla. That's that widened area. This will work. The widened area at the bottom there with the arrow coming out of it, that is the ampulla of each semicircular canal has one of those with a cupula in it. The cupula is the gelatinous material that surrounds hair cells. It is the deflection of that cupula when endolymph in the semicircular canal passes over it that causes the firing rate in the vestibular nerve to increase or decrease depending on the movement of the head. This is just another close-up picture of that. Do you guys want the lights off? Would that be better? Or are you okay? Is you okay? Okay. So further on the peripheral system, there's 2 otolith organs. These are those also called maculae. These are the organs that the calcium crystals sit on. Calcium crystals, also referred to as otoconia. The 2 otolith organs sense linear acceleration. There's the saccule and the utricle. Those are the 2 organs. The relationship between the utricle and the posterior semicircular canal is an important one. The utricle sits near the opening for the posterior semicircular canal and is the reason that that canal is mostly involved in BPPV. That's the most common canal that you'll see. The otoconia fall off of the utricle and into that canal. Other canals can be involved as well, but that's more rare. Each maculae consists of a gel matrix with a piece of gel sitting on hair cells and with calcium crystals or otoconia attached to it. This is a picture of a utricle. So there's your gel on top with the crystal sitting in it and with underlying hair cells. So again, deflection of those hair cells from movement of your head is what increases or decreases the firing rate. So the alignment of the canals. If we place our hands here, this is like a vestibular thing. Put one hand here, one hand here. This is your anterior canal and posterior canal. And then you can think of your horizontal canals being like this. There's like a joke that this is the vestibular handshake. Kind of corny. But so that's how you can think of the alignment of the canals. So the utricle is in the horizontal plane, and so it's detecting forward and back movement. The saccule is in the vertical plane, so it's detecting up and down movement. This is a picture just to show you that. So as you can see, as the head moves forward, there's your utricle sensing that motion. I put this in there just to note that although we say mostly horizontal and vertical, it's mostly horizontal and vertical. You can see that there is some unevenness to it. It's not perfectly horizontal and vertical. I'm going to briefly go over innervation and blood supply. So the innervation is via the vestibulocochlear nerve, the eighth cranial nerve. This splits into a superior and inferior division. This becomes important when we're thinking of things like a hypofunction, but so that's why I put it in there in case questions about that come up. But the superior division innervates the anterior semicircular canal and horizontal and the utricle. The inferior is the one that innervates the posterior semicircular canal and the saccule. So as I was saying before, like the utricle is the is where the otoconia commonly fall off and fall into the posterior canal. So if there's damage to the superior division of that nerve, then the utricle can degenerate a little bit easier. Those otoconia fall off and into a well-innervated posterior semicircular canal. A hypofunction commonly goes along with BPPV, so that's where that relationship is. And this is a picture to show you that. You guys can feel free to just come in and find a seat. I don't know if there's any handouts left, though. So here's a picture of the vestibular nerve, and you can see the superior division going to the utricle, the anterior canal, and the horizontal canal, and the inferior division going to the saccule and the posterior canal. I added another picture. I just liked both of these pictures. I thought they showed it well. As far as central vestibular anatomy goes, the exact location of the vestibular cortex is not really known at this point. They think it's multiple locations. I added this quote. The vestibular cortex can be defined as the networks of all cortical areas receiving inputs from the vestibular system, including areas where vestibular signals influence the processing of other sensory and motor signals. In this picture, you can see where the primary auditory cortex is. All along that area is where they think the vestibular cortex lies in multiple areas around that area, depending on what type of sensory stimulation you're providing the system. So a brief overview on arterial supply. The anterior inferior cerebellar artery, also known as the APTA, it splits into the anterior vestibular artery, which supplies the utricle, the ampulla of the horizontal semicircular canal, and the anterior semicircular canal. So again, kind of that same split that you saw before with the innervation. The common cochlear artery portion of that splits into the main cochlear artery and the vestibulocochlear artery. So when we have a stroke of the APTA territory, you may end up with hearing loss and some vestibular type symptoms. When you're doing vestibular rehab, you're always thinking central could be a possibility, so you're always screening for these things. That's why the anatomy is important. The posterior inferior cerebellar artery, or the PICA, supplies the inferior vestibular nuclear complex in the dorsolateral medulla, as well as the inferior portion of the cerebellar hemispheres. This is a picture just to show. You can see APTA and PICA. So just, again, as a note, why we're looking at this. The cerebellum monitors vestibular performance and keeps it calibrated. Lesions and strokes affecting these areas can cause dizziness due to the vestibular nuclei that lie in those areas and the connections from the vestibular system to the cerebellum that run through the pons. So when you're treating a dizzy person, you're always looking for central signs. Okay. Any questions up until now? Or comments or anything? Okay, so that's all. I know that was a lot, but it was not the focus of our presentation. I just wanted to get it out there. So now this is more of what we're talking about. So when a dizzy person comes to you, just like with anything else, the history is going to be one of the most important things that you get from them. You try to get your patient to describe their dizziness. Common descriptors are lightheadedness, and when somebody says that, it commonly leads us to think this could be cardiac, like a BP or an arrhythmia, or possibly cervicogenic. They may describe their symptoms as spinning of the room or spinning in their head, an illusion of movement, or being off balance. And I think it's important to note that sometimes the only complaint they may have with BPPV is being off balance. They may not report having vertigo. Possible causes of vertigo, and I'm listing these quickly. We're not going into these. CVA, or concussion or brain injury. People often have motion sensitivity, but we should also be thinking about BPPV with these. Migraines. These people also often have motion sensitivity and visual dependence. They don't have to have a headache to have a migraine. They don't have to have a headache with their vertigo. They're usually light and or sound sensitive. They have vertigo that can last for minutes to days, and they may also have BPPV. It can be more common in people with migraines. Another cause would be BPPV or MS, a vestibular hypofunction, a unilateral one, or an incomplete bilateral, superior canal dehiscence, an acoustic neuroma, or vertebrobasilar insufficiency. So the take-home message here is not all vertigo that you get in the office is going to be BPPV. Okay, so I'm going to demonstrate this. I mean, you're welcome to practice along with somebody next to you while I demonstrate this. For time, I wasn't going to split into groups and have everybody practice. This is more the screening part of what you're doing with somebody in room light when they come into you for dizziness. I'm using Liz as my patient. Yeah. And you can move around however you need to see. So a lot of what we're doing here is really screening for a central problem, even though tonight's BPPV. So I'm going to be looking at my patient, and first I'm going to be looking for, do they have a spontaneous nystagmus? So at rest, is there a nystagmus present? If you're being really good, you're going to be holding their head still while you're doing it. So look straight ahead. I have her hold it. I'm going to go through this kind of quickly, and then I have her look to one side, not all the way to one side because that might produce a nystagmus just because she's at end range, but slightly to one side, slightly to the other, up, and then down, and lifting an eyelid to look, and you may have them go down and over as well. That might pull out a nystagmus a little bit better. So what I'm looking for there, central signs would be if I'm looking at her and I just see a vertical nystagmus. So remember, nystagmus is a fast phase and a slow phase, the jerk nystagmus that we're going to typically see. And then when she's looking side to side like that, I'm looking to see, is there a nystagmus? Does it change directions, or does it stay in the same direction, depending on which way she's looking? And that can be more common with, if they have a hypofunction, so one side isn't functioning as well as the other. Let's say it was on the left. When she looks to the right, and it's an acute, it just happened recently, she looks to the right, I'll see a really strong right beating. She looks center, it's a little bit not as strong. And if she looks to the left here and holds, it might be even less strong. And that would be a really acute hypofunction. Because she's in room light and because that's in all three directions there. That's what I'm getting off tangent with that. So that's what you're looking for. If it's a central problem, so she looks to the right, I might see right beating, looks left, I see left beating, looks up, I see up beating, looks down beating, that's bad. You don't want to see that. Okay. So now I'm going to be looking at smooth pursuits with her, and you're going slow enough because if you go too fast, you might see saccades. And that's a jumping of the eye. that would be a central sign. I'm going in all directions because I'm also screening for a cranial nerve exam as well. And if you see saccades and your patient's older, you don't want to take that as being that meaningful. It might just be that they're older, and that happens in older adults. So then we're looking at saccades. So I'm having the patient look at my nose. Now look at my pen, look at my nose, looking at my pen, look at my nose, in all directions. And I'm looking for speed of movement, and especially looking for overshooting. That would be similar to like overshooting a target. And is there a latency? So when I say shift your focus, is she waiting and then shifting her focus? All right, went through those three. I can't remember everything I listed on the slide. So looking for trained nystagmus or optokinetic nystagmus is another test of the smooth pursuit system. So looking for another. If I cannot get this in her, it might be a central sign. So I'm going to shift this by her and tell her to just look at it, don't follow it. And if you're sitting here, you can see her eyes moving. And I do that vertically and horizontally. VOR cancellation, again, another looking to see, can she not cancel her VOR? That's a central sign. So I'm holding her head, having her look at my nose, moving her side to side, and I should not see any refixations as I go. This is a fun one. Would you mind holding this chart? Okay. So I have somebody holding the chart because I don't have a good home for it downstairs. And this I'm looking at, this is dynamic visual acuity versus static. So I would have my patient read the lowest line on the chart there that she can. Let's say, you would be closer than that, but that's okay. So let's pretend Liz could only read to here on this line. That's her static visual acuity for the purpose of this test. Then I get my metronome out. I turn it on at 120 or 240, and I turn her head like this and make her read as low as she can again. And so I'm looking for the difference there in what can she read statically and what can she read dynamically. And the difference of greater than 2 lines is an impairment in gaze stability. And you want to make sure that the head is tilted 30 degrees, so that way you're getting the horizontal canal with that test. Because remember, we talked about horizontal canals are like this. So you're bringing them into the plane here. And then our bread and butter is the head impulse test. Again, tilted down 30 degrees. And I'm doing some unpredicted head movements here. Looking to see if, as I turn her head fast, if her eyes wait a second and then jump back to me. So it has to be unpredicted, quick impulse. That's more looking for a hypofunction, but sometimes your hypofunctions go along with your BPPV as well. So it helps you to locate which side as well. A skew deviation is one eye lower or higher than the other. That can be central or it can be a hypofunction. And then looking at her ability to converge, and having her tell me when it gets blurred or double. It should be right about where it is for her, and her pupils should constrict with that. If her one eye doesn't go in or one eye goes out or is not conjugate, I'm going to note that. Okay? All right, thank you, Liz. Do you guys have any questions on that part of it? So that's in room light. The next thing I would be doing, my phone, is more screening for central signs. So still looking for central with a gross cranial nerve exam asking about checking for sensation changes. There's one patient I always have in mind when this happens that saw me for BPPV, and then told me during her eval that she had been getting tingling in her face for a year. It turned out she had TIAs, and then she went on to have a big stroke the next day. She didn't go to the doctor. Didn't go to the ER when her doctor told her to that day. When I called them and said, she's been having tingling in her face. So, and she had an ICA stroke, so that where she lost hearing of that as well. So gross cranial nerve exam is really important. Limb coordination, so because of the cerebellum, as we were talking about before, you're looking to make sure that they're not having in coordination ataxic movement. Looking for clonus, the Babinski sign, and DTRs. Okay, so now on to why we're here. BPPV is the cause of at least 50% of dizziness in older adults. It's the most common cause of vertigo. The incidence is 64 in 100,000 people per year, and the lifetime prevalence is 2.4%. About 50% of patients also report being off balance. And so again, just being off balance may be the only complaint they have. So if you're seeing somebody for balance and they're not getting better, you might want to consider looking for BPPV. The most common form of BPPV is canalithiasis. That's the one where those calcium crystals are free-floating around in the canal. With this, you're typically going to see short duration vertigo, so lasting less than 60 seconds. It's going to be positional in nature, so it's not constant. They're not always having vertigo. It's when they get into specific positions, and there's a latency. So you get them into the position, it's typically 5 to 30 seconds before you see it. The other form of this is cupullolithiasis. This is where those otoconia actually attach to that cupula. So because that cupula is then affected by gravity, and there's a little piece of rock on it, what we think happens is as the head tilts down, it immediately deflects. So immediately changes the firing rate. That's why there's no latency when you move into the position. And it's non-fatiguing because as long as that crystal's on the otoconia, it's pulling on it and is sending those signals, and it's also positional in nature. The posterior semicircular canal is the most common. It's 81 to 90% of your BPPV. The horizontal or lateral is 10 to 15%. Anterior is only 1%. So with the type of nystagmus that you would get with anterior is a downbeat with a torsion. Downbeat is also a very strong central sign. So if you ever see that, you should be assuming more of this is probably central, and I need to rule that out before thinking it's the anterior canal. This other form is ageotrophic posterior semicircular canal. Also not really common. It's just that those otoconia are in a different spot in that posterior canal and can make it look as though it's an anterior canal. So the test for BPPV, Dix-Hallpike test is still the test for BPPV. And when you're putting somebody into that position, you're going to see, you're testing for posterior canal, but you may see anterior canal. The direction of your nystagmus is what leads you to know what you're seeing, what canal is involved. So typically what you're going to see is, let's say you're moving somebody with their head to the right and into the Dix-Hallpike, you're going to see a right torsion with an upbeat. That's a right posterior canal positive test. There should be a latency again. It's of short duration. That's all what's going to guide you to knowing it's canalithiasis. If it's no latency and non-fatiguing, that's where that crystal is adhered to the cupula. But you may also see the anterior canal or the other variant of posterior canal in this position. Remember, nystagmus is named for the fast phase. It's important to use Frenzel lenses or infrared goggles, if we have the goggles here, when you're testing for this. Peripheral problems with the vestibular system, like a hypofunction or like a BPPV, are going to be viewed more easily when you block out all light. Your brain can suppress the nystagmus when you have room light. So if you're going to be seeing people with these problems, it's important to have goggles for diagnosis and treatment. And that we do have those downstairs as part of the demonstration if anyone wants to see that. So this is a little names and nystagmus game. This is what it looks like when you have the goggles on. So you can see that's an up. Oh, that wasn't it. That was probably just moving into the position. There it is, up and right. The eyeball's going like that. So that's up feeding and a right torsion. That tells you right posterior canal. And there was a latency, and it's of short duration. It's not going to keep going. It fatigues. And it has that crescendo and decrescendo. It gets faster and then slower. You guys want to see that again or no? Anybody? Yeah? Oh, hang on. There it is. And so it's going up, but it's also rotating this way, up like this. You can pull out like a blood vessel in the eye sometimes to see what you're looking at. That's what I usually try to find, a blood vessel or somewhere in the iris that kind of stands out to watch the direction of that movement. It's named for the superior pole of the eye, but you'll just find that those are little ways to make it easier. Okay, so up feeding with right torsional. So here's another video. So she's showing you the left dick sulfite. So head was turned left 45 degrees and then taken back into about 20 degrees of extension. And so with the goggles on, this is what they're seeing. So this one's going, see that one has a nice little piece in the iris that you can watch coming up. So it's going up and over to the left. And it's short duration. There was a latency. Okay. You want to see that again? Yes? Yes? Oh, music was listening. So if you watch that little piece in the iris, it's going up and over.
Good morning, and welcome to Westwood, California, and welcome to the Ronald Reagan UCLA Medical Center. My name is Isaac Yang, and I'm the lead neurosurgeon for the Superior Semicircular Canal Dehiscence Program at UCLA, the SSCD program. And as the lead neurosurgeon for this, I'll be talking to you today about SSCD, Superior Semicircular Canal Dehiscence. This live webinar is being brought to you from Westwood here at UCLA. I'm very happy to bring this to you over the internet.
Okay. Oh, there's a lot of videos open here. Okay. So that was left torsional with an upbeat. It's important it's named that way. It's not a left upbeat. It's a left torsion with an upbeat. Okay, so the Dix sulfite is still your gold standard test. Sensitivity and specificity is 82% and 71%. An alternative test, though, a very good test, is a side-lying test. I don't have a picture of that one, but let's say you're testing for right side. They're sitting on the edge of a table. They turn their head to the left and lay down on the right side. And you're looking for the same pattern of nystagmus that you'd be looking for in a Dix sulfite. There are contraindications to this test. You want to think about ligament laxity. So people with Down syndrome or severe rheumatoid arthritis, cervical myelopathy or Arnold-Chiari syndromes, anything that you're not going to want to extend the spine. Recent acute trauma to the neck, if you, again, you're thinking about ligament laxity. I added in here also to consider carotid artery stenosis, moderate to severe, because you're taking them back into that extended position. Vertebral-basilar insufficiency or a VT shunt, anything that you don't want the head down below the rest of the body. If anybody didn't get a handout and wants one, you guys can just email me, so don't worry about writing it all down. So the instructions for the Dix-Hall pike, and there's a diagram in here too. Patients in long sitting, you have them turn their head 45 degrees. If we're testing the right, they turn their head 45 degrees to the right. You lay them back quickly, supporting their head. Their head is only extended 20 degrees. You're looking for nystagmus. You're staying in that position for at least 30 to 60 seconds. Let's say you see a positive test. Then I'm waiting 30 seconds beyond the nystagmus stopping. When they return to sit, you may see a reversal of the nystagmus. So if it was a right-sided DPPV, I take them back, and I'm getting a right torsion with an upbeat. When they sit up, I may see a downbeat with a left torsion, and that's just cool to see because you're like, okay, yeah, that's definitely what it was. You don't always see that. This is a diagram of the Dix-Hall pike test, and that's for the right side. So the treatment, a treatment for this is not called APTA maneuver anymore because they've taken away some of the pre-medication, the vibration to the mastoid, the postural restrictions that were given after that. So now we call it either modified APTA. You'll also see it referred to as canalus repositioning maneuver, canalus repositioning procedures, or canalus repositioning techniques, some variation of that. This is showing you treatment for the right side. So starting in that Dix-Hall pike, really in that test, you take them back, you're waiting for that nystagmus to resolve, plus 30 seconds, take their head over to the left, still extended, wait however long you have to wait in the first position, that's how long you're going to wait in the second position, and then you keep their neck back as you rotate them with their chin tucked onto that side, and then sit them up, chin tucked, head face to the left. You're doing the right side. I stay in each position 30 seconds beyond what it took in the first position for the nystagmus to be gone, unless they're really nauseous or something and you need to whip them through it. So this is an extremely successful treatment. 32, depending on what you're looking at, 32 to 90% of people are successfully treated after just one session. One session may be like 4 times in that one session. Sometimes you only need it to be done just once. If they're not successful the first time, 17 to 100% of them benefit from a second treatment.
I'm not talking right now. I told you.
Successful treatments after the first maneuver in
If I get a break, I'll
is 84%. So, and then if it doesn't work after the first maneuver, that success rate increases to 90 and 92% after your second and third maneuver. So it's just a very, very good treatment. During the canalus repositioning maneuver, you're looking for nystagmus. You're asking them about vertigo. Are they experiencing vertigo along with their nystagmus? I thought this was interesting, is that vertigo during that second head position, so you take them back, they have a positive response, you move them into the second head position. If they're also getting vertigo during that, that might indicate that you have a successful maneuver. And what you're looking for is nystagmus to be in that same direction because it's showing that the otoconia are still flowing away from the cupula. So there's an app for this, if you forget how to do it. There's an app called Dizzy Fix. It actually walks you through it. I know you're not going to be able to see this, but I have the light version. You can pay to get a more advanced version. So it has you place, it has a person's face on it. It has you place it on their forehead. It'll tell you rotate their head to 45 degrees. And when you get there and it senses it, it says, okay, now tip them back. And it'll tell you, like, how much you're tilted or not tilted. And it'll tell you, like, how long to stay there. And if you get a positive response, then you need the not light version. You have to pay to find out how to treat them. And then the AVOR, this is an awesome, fun tool to play with. This is a little guy's head, and there's all different things you can do with it. You can go in and set it where he has right-sided BPPV of any canal. or a hypofunction of any canal, and you move its head around and you see what his eyes would do in that different positions that you would put him in. So it's just a fun app to play with. Any questions up until now? Okay. So the alternative treatment, if you don't want to do the modified Epley maneuver, for various reasons, is the CMOT maneuver, also called the liberatory maneuver. This is more commonly also done with somebody who has acute lithiasis. This is, I like to do the modified Epley. I think it's easier to do on most patients because this one, let's say it's a right-sided issue, it's going to look just like the side lying test at first. So they're going to turn their head to the left. You lay them down quickly onto their side and wait. Waiting for that nystagmus to resolve. And then in less than 1.5 seconds or 1 second, so said, you have to get them up and over, nose down on the mat, that all the way down on the mat. So that part can be really hard to move people through, especially a lot of the people that I see that are older, that don't move like that. And you're going to wait there 1 to 2 minutes. So you can use that for canalithiasis or acute lithiasis. This is a picture of it. So head is, she's treating the right side. Head is to the left, laying on the right side, up and over in less than a second, and then waiting for a minute or two. So in a study that compared these two maneuvers, found the treatment to be successful actually in both. It's a similar amount, but Epley actually had a small but significant increase in canal conversion. That's where you have to be careful when you use the modified Epley, is that you can cause it to convert into a Barthonia may move from the posterior to the horizontal, especially if you lift their head up for treatment. So they're saying that the reason that CMOT may have less of that conversion rate is that there aren't as many head-dependent positions in it. This is interesting. We don't have this here. This is the vertigo treatment chair. It's called, I've seen a couple of different names for it. One is the Epley Omnimax chair. And so you can just, I think it's all computerized, and you're just kind of flipping your patient around to test them and to treat them. So it's great for people that have a lot of musculoskeletal impairments that can't move into certain positions. You strap them in a chair and move them around. And actually, the study that I looked up on this, that I think is in your references, the success rate is a little bit higher with this as compared to using the modified Epley. So if treatment's not working, after a couple of sessions, I would say like 3 sessions, you need to start thinking about differential diagnosis. Maybe something called a superior canal dehiscence, where part of the bone in the superior canal is not there anymore. A Chiari malformation, MS, a cerebellopontine angle tumor, something they need a further workup from a physician, so send them back to the physician. Risk factors for treatment failure. Being greater than 50 years old. Part of that in this article talked about just some of the, that sounds young, but some of the restrictions people may have on movement if their musculoskeletal system isn't as mobile as somebody less than 50. Secondary BPPV, so meaning BPPV that's resulting from having had like Meniere's disease or neuronitis first. Head trauma, and I was glad to see that because I've thought that before, is that when you're treating someone who's had a head injury, that it can be a lot harder to resolve. And what they're saying is a lot of those crystals may stick to the side. There's been so much trauma to that area that there may be some trauma to the membranes themselves, and cause like the crystals to kind of stick to the membrane instead of being free floating more. Osteoporosis, again, because of like positioning, and then if it's anterior canal BPPV, it's a higher treatment failure. So the discussion on postural restriction. So with the classic Epley maneuver, there were these restrictions that were given: sleeping upright for 45 degrees for 48 hours, wearing a cervical collar, don't lie on your involved side for 5 days. This one Cochrane review did show a statistically significant but small improvement in that treatment efficacy of number needed to treat of 10. so 10 people in order for one of them to benefit from it. So we generally do not recommend that severe of a restriction at this time. I have more on this, though. So this was interesting. One article talks about taking the vestibular apparatus from a bullfrog, and they removed some otoconia from the utricle and then placed it back onto the utricle in various spots. Then they waited 3 to 5 minutes, and tipped that. And after it was, and they held it in for 10 seconds. After that, they had waited 3 to 5 minutes, they found that the otoconia stayed there. So under those 3 conditions, the otoconia were stabilized back to the utricle after 3 to 5 minutes. So that's kind of interesting. But the thing is, we don't know that that's exactly what is happening anyways. That's just one theory of what might be happening to those otoconia after you reposition them. They might get absorbed into something called the dark cells around the utricle. They might just kind of break up within the endolymph. We don't really know. But I just thought that was kind of an interesting article. What the APTA fact sheet has, if you're a member of the neuro section of the APTA, you can go up to into their vestibular special interest group, and they have a ton of information. It's a really great special interest group. They have fact sheets for physicians and fact sheets for patients, and I use a ton of the patient ones to hand out for educating your patients. And this is just one section of that fact sheet that they recommend for several hours, keeping your head relatively still. You can resume sleeping that in your normal position that night, and you should go back to your normal activity the next day. Most of the time, I follow this. Every once in a while, if it's been somebody that I've had to treat a few times to get it to resolve, or somebody that was really, really hard to get through the positions, I might tell them, wait a day to go, don't sleep upright tonight. And then this question comes up, is there spontaneous resolution? If I don't get treatment for it, will it get better on its own? So this review reported that it was unclear, but one study said 84% of people will have resolution in 3 months. Another reported that after 12 months, the resolution is down to 15%. A recurrence rate, so this is another question that comes up, is will it happen again? It reoccurs in about 33% of patients in 1 year and 50% 5 years after a successful treatment. And then another study reported 48.4% in 3 months. So that's kind of contradicting to each other. But yes, it can recur. Any questions now? So that's it for the lecture part of it. So whoever wants to stay, I have the goggles downstairs. We can go down and practice and demonstrate the Dix-Hall pike, the modified Epley, the liberatory maneuver, and answer any questions you might have about using the goggles or any of those positions. But right now, if you have any questions on anything we've talked about, go ahead. Yeah.
If you don't mind, could you just repeat the question after or whoever asked it, the viewers or the listeners here?
Oh, okay.
So why is it the Dix-Hall pike assesses for posterior BPPV but not lateral? And then, with that the case, how would you assess for lateral?
Okay. So the question is, why does the Dix-Hall pike position assess for posterior rather than lateral canal BPPV, right? Mm-hmm. And how would you assess for lateral canal BPPV? So it has to do with the alignment of the canals in relation to gravity. So again, posterior canal is kind of like this, if you're thinking about the planes. And for people that can't see, I have my hand on the back of my head here. But you're tipping them back and putting that canal in relation to gravity, where the otoconia are going to be gravity dependent and falling and pulling on the cupula and deflecting the cupula in a way where it's stimulating that. So that's why it's looking at posterior canal. If you look at the relationship between where posterior canal is and anterior canal are, they are both going to be gravity dependent somewhat in that position. So you may see some anterior canal symptoms there too, or a sign of anterior canal BPPV if it's there. Horizontal canal is like this. So if we're going to test for that, we're going to use something called the roll test. Basically, the patient is laying supine with their head tilted 30 degrees or flexed 30 degrees. Although I have heard some people say now that they don't flex their heads 30 degrees, they keep them flat. But generally what you're going to find if you look it up is heads flex 30 degrees so that the line of the canal is in relation to gravity or in relation to the floor is perpendicular. Then as they roll, you have them roll onto one side. You can do it with head turning to one side, but then I very rarely do that. I usually have the whole body roll so that the neck is taken out of it. So I keep their head and neck together, have them roll to one side so that their face is perpendicular to the floor, right? Am I thinking of that right? So their face is directly side. And so let's say I roll somebody to the right. What you're going to see if it's a canalithiasis would be a nystagmus that beats towards the ground. So it's called geotropic. There's a push-pull mechanism with our canals. So as I stimulate the right, I'm actually causing the firing rate of the left to decrease. So as I roll them to the right, I'm going to see geotropic nystagmus towards the ground. But I'm also going to see something when I roll them to the left. So you should expect to see something right and left if it's horizontal canal. So when I roll them to the left, I should also see geotropic nystagmus. And if it's canalithiasis, it's going to be short duration. There's going to be a latency. If it's cuculolithiasis, it's the opposite of that. So I roll them to the right, it beats towards the ceiling, called ageotropic. Roll them to the left, it beats towards the ceiling, ageotropic. Non-fatiguing, no latency. And the other thing that's tricky about the horizontal canal is that the intensity of it, so let's say it's right-sided horizontal. I roll them to the right. I'm going to see towards the ground, so like a right beat, but towards the ground. Geotropic nystagmus. It's going to be a stronger symptom report by the patient, stronger nystagmus, stronger symptom report with that side that's affected. It's the opposite for cupulo. If it's on the right, I'm going to have a stronger symptoms when I'm on the left.
Thank you.
You're welcome. But because horizontal canal is a lot more rare than posterior canal, that's why we were talking about posterior canal. But you can convert with YouTube now. People are looking vertigo up on their own and doing self-treatments on their own. So there's a little bit of a rise in horizontal canal because people are doing it at home and converting it to a posterior canal into a horizontal canal. And horizontal canal is harder to diagnose the right side and harder to treat.
So that's just posterior canal, most common position that which like that after the crystals break up.
So the question is the posterior canal BPPV the most common because of the anatomical relationship of where the utricle and the posterior semicircular canal. That's why it is the most common, and because it's that posterior canal is gravity dependent. And if you get a neuritis, an inflammation of the vestibular nerve, and it's that superior division, you're going to allow for degeneration of the utricle. So those otoconia are going to fall off a little bit easier. But that posterior semicircular canal is still well innervated and going to experience those symptoms.
So it's positive on both sides for the.
So bilateral BPPV is uncommon, but it can happen, and especially if there's like a head injury, that's when I'm going to think of that more. I would try treating whatever side is more symptomatic or whichever one you happen to find in the Deblois lake, but I would only treat one in one session, and then check them again when they come back. And then, so if you clear one side, then do the other one the next time. It's really uncommon, but it can happen. So the question was, what if somebody's positive on both sides of the Deblois lake? Oh, really? Oh, okay. Yeah. Okay. Yeah, and I would always keep in the back of your head too, like, is it definitely a BPPV or is it something else? But if you see if you can treat it, clear it, and then see if you can treat the other side and clear it. Yeah.
Is there anything you recommend to your patients to avoid it from recurring?
As far as I know, there's nothing that you can really do to avoid it recurring other than some of the postural restrictions the day of. So can you think of anything? The question was, is there anything you can recommend to your patients to avoid it from recurring? No. Okay. what I always do with people for sure, if someone is, who's feeling they could self-treat, is I usually give them a handout on how to self-treat. They know what BPPV feels like. In that way, at least we get them, they can try it at home, and then we try to get into practice. So, Liz suggested that some people may, if they have, I would say, like, if I have somebody that I think definitely is able to do the self-treatment okay at home without causing a conversion, and they get it repetitive, they've gotten BPPV repetitively, and we've seen it's always the same side, always the same canal, then I might give that person something to do at home to treat it. But I like to see them, I like to make sure that it is always the same canal, and then do that. I can't say that happens a lot, though, because it is a successful treatment, so you don't get that many people coming back again for it. I heard that if they keep getting there has a surgery that's a plug 6 canal, so it just... There is so the question is, somebody mentioned that she's heard that you can get a plug for this, and there is that. Surgical. Yeah, surgical treatment. That's really rare. But yeah, that is something that if it can't resolve, if it keeps coming back, they might do a surgery for that, but it's extremely rare. Okay. Oh, was there another question? No? Oh, okay.
We also have a sign-up sheet. We'd like you all to sign up to get your CE credit. And you can give your payment to me. Is there something else you wanted us to talk about?
Well, for you to get your CEUs, I need you to fill out a course evaluation, and I unfortunately forgot to make copies before I came today. So hopefully I can do that, and please, for your CEU card, make sure you sign in legibly, and